Okay, I'm going to be walking into the patient's room and I will perform hand hygiene for 20 seconds and then I'm going to close the curtains to ensure privacy. I'm going to introduce myself to the patient. I am your nurse today. My name is Molly. What is your name?
Amanda.
Amanda, nice to meet you. I'm going to assess the patient's level of consciousness, so I'm going to ask her if she knows where she is today.
The hospital.
And then can you tell me the year?
2020.
Perfect, so the patient is alert and oriented ×3 to person, place, and time. Next, I'm going to have the patient shake my hand. Perfect, so this assesses the motor portion of the Glasgow Coma Scale. So I would give her a 6. Her eyes track me when I walk into the room, so she's gonna get a 4 for the eye response, and then she's able to form a cohesive sentence. So she'll get a 5, coming to a total score of 15, which is normal for the GCS. Next, I'm going to ask the patient if she has any allergies.
No.
Do you have any past medical history we need to know about?
No.
And then do you take any medications at home, over the counter, or herbal?
No.
Perfect. What brings you to the hospital today?
I had a seizure.
A seizure? Okay, can you tell me a little bit more about that? Was anyone there to witness a seizure?
No.
Have you had them in the past?
No.
Did you have any aura or weird feeling before the seizure happened?
No.
Did you lose control of your bladder or your bowel during the seizure?
No.
And then how did you feel after the seizure?
Fatigued.
Okay, so since the patient indicated that she didn't lose control of her bowel, we know that this wasn't a grand mal seizure, so that indicates the severity. Next, we are going to move into the vital signs. So we're going to use our blood pressure cuff, and we're going to use the 2-step method. So I'm going to wrap this around the patient's upper arm. I'm going to ensure that it is tight, but not too tight so I can fit 2 fingers underneath it and it's not too loose. Next, we are going to assess the radial pulse, and then I'm going to pump up the blood pressure cuff until we no longer hear this pulse. We're going to say this ends at 100, and this will be our pulse for the next step. So then I'm going to put my stethoscope in, put the diaphragm on the brachial artery, and then we're going to puff up the blood pressure cuff again, and we're going to pump it up until 20 or 30 milligrams of mercury above that 100 that we first heard. So we're going to pump it up to 130 and then slightly release the pressure. The first sound we hear is going to be our systolic blood pressure, and the last sound we hear will be our diastolic blood pressure. Normal will be 120/80 to 90/60. The next vital sign we will assess is the heart rate. So I will go and look at the radial pulse near the thumb, count this for a full minute, and this should be 60 to 100 beats per minute. Next, I will move the patient's hand over the chest to assess the respiratory rate, full inspiration and expiration, and this should be between 12 to 20 breaths per minute. Next, we're going to do the temperature. So I'm going to put the temperature probe underneath the tongue, have the patient close the mouth, and this should be between 96.4 and 99.1 degrees Fahrenheit. Next, we will do pulse ox on the finger. This should be anything above 95%. Next, we're going to look at circulation. Using the dorsal portion of our hand, we're going to assess the skin, and the temperature should be dry, warm, and normal for the patient's ethnicity. We're also going to look at the capillary refill. We're going to press down on the nail bed, and this should refill in 2 to 3 seconds. Next, we're going to move into the pulses. We grade these on a scale of 0 to 3. 0 being no pulse, which we would confirm with a medical provider. 1+ being weak and thready. 2+ being normal, and 3+ being bounding. So we're going to begin with the temporal arteries on the forehead. And then we'll move to the carotid artery, being sure to only do one at a time to ensure proper blood flow. Next, we will do the brachial artery, which is on the crease of the elbow. Next, the radial artery on the thumb side of the hand. We'll assess the apical pulse on the lower chest, and then the femoral artery right in between the groin. Next, the popliteal artery on the back of the knee. Then the medial posterior tibialis on the medial side of the ankle. and then the pedal pulse between the big toe and the first toe on the top of the foot. Next, we're going to have the patient stand up, and we're going to look at the thyroid gland. So I'm going to palpate from behind, letting the patient know that I'm coming from behind. We're going to give the patient a glass of water and have her take a sip. And while she swallows, we're going to make sure everything is normal and we don't feel anything, and it will be slightly larger on the right side. Next, we are going to have the patient sit back down so we can assess the lymph nodes. We're going to start with the pre-auricular right above the, or right in front of the ear, and then the post-auricular right behind the ear, the occipital behind the hairline, and then the submental is under the chin, submandibular underneath the jaw, jugular digastric underneath the earlobe, the superficial cervical on both sides of the trachea, and then we're going to have the deep ones in the same area, just a little bit deeper. The posterior cervical are going to be on both sides of the spine, on the back of the neck, and then we're going to have the patient hunch forward, and then we're going to assess the supraclavicular lymph nodes in that notch. We also have lymph nodes in the armpit, and then the epitrochlear lymph node is on the crease of the elbow, and then the inguinal in the groin. Next, we're going to move to the assessment of the cranial nerve. So we're going to have cranial nerve number 1, which is olfactory, and that's our sensory nerve. So we're going to have the patient occlude one side of the nose and breathe in and out. And we're going to repeat that on the other side, and we can tell that the nose is patent. Then we're going to have the patient close the eyes and occlude one side of the nose and have her smell and identify this.
Coffee.
Perfect, and we would repeat that with the other side. Next, we will move to cranial nerve number 2, which is the optic nerve, another sensory nerve, and we're going to go ahead and perform the confrontation test. So the patient is going to cover her left eye, and then I'm going to cover my right eye, and she's going to identify when she can see me wiggling my fingers.
Yes. 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 Yes.
Perfect, so that nerve is intact. Next, we're going to observe cranial nerves number 3, number 4, and number 6, which is our oculomotor, trochlear, and abducens, and these are the sensory and motor nerves. We're going to perform PERLA, and this is the pupil's equal, round, reactive, and accommodation to light. So we're going to have the patient look off in the distance, and we're going to bring the pen light in from the outside, and we should have constriction of the first eye, and then we should have consensual constriction on the other eye, and we'll perform this on the other side. Next, we will look at cranial nerve number 5, which is a trigeminal nerve, and we're going to use a cotton wisp to assess this. We are going to demonstrate what this should feel like on 3 portions of the face, and then we're going to have the patient close the eyes, and then she's going to point to where I am putting the cotton wisp. Perfect, and that nerve is intact. Next, we are going to move to the facial nerve, which is nerve number 7. We're going to have, this is a motor and sensory nerve, so we're going to have the patient puff her cheeks, smile, and frown. Perfect, and this nerve is also intact. Next, we'll move to cranial nerve number 8, and this is the acoustic, and we're going to, this is a sensory nerve, so we're going to have the patient stand up, and then we're going to have her occlude her ear on the left side. I'm going to stand on the other side and whisper 3 words, and she's going to identify those.
Apple. Orange. Wine.
Perfect. And then we're going to have the patient sit down again, and we're going to assess the glossopharyngeal and the vagus nerve, which is nerve 9 and 10, and these are sensory and motor. So we're going to take a tongue depressor, have the patient stick out their tongue, press it down, and have the patient say ah.
Ah.
We're going to look at the uvula, make sure it's midline and that the soft palate rises when she says ah. Next, we're going to look at the spinal accessory nerves number 11, and these are motor. We're going to have the patient shrug her shoulders and then turn her head to the left and the right, and then she will perform this against resistance. Perfect. Perfect. So that nerve's intact. Lastly, we have cranial nerve 12, which is the hypoglossal, and this is a motor nerve. We're going to have the patient stick out her tongue and observe for any tremors. She doesn't have any, which is normal response. Next, we're going to move into the cerebellum function. We're going to have the patient stand up again. She's going to walk from point A over here to point B, which is about 20 feet. We're going to observe for any difficulty walking or sidestepping, and she performs that with ease. Next, we're going to look at the Romberg test. So we're going to have the patient stand in front of us, arms at the side, and then close her eyes. We're going to protect the patient in case she falls. We're going to observe for any swaying, any sidestepping, and she's perfectly normal. Next, we're going to look at some sensory cerebellum functions. So we're going to have the patient take a seat again. We're going to take a sharp and a dull object. In the clinical setting, we would use a tongue depressor and break it in half, but we're going to use a fork today. So this will be sharp. We're going to demonstrate that. And this is dull. Then we're going to have the patient close the eyes and identify which is which.
Sharp. Dull.
Perfect. Next, we are going to assess for kinesthesia. So I'm going to take the patient's hand. I'm going to demonstrate what the up motion would be and what the down motion would be. I'm going to have the patient close her eyes and identify which is which.
Up. Down. Up. Down.
Perfect. So that is intact. We're next going to look at stereognosis. We're going to place a familiar object in the patient's hand, have her close her eyes, and identify what that is.
Paperclip.
Perfect. Next, we're going to look at graphesthesia, have the patient keep her eyes closed and draw an object or a letter in the patient's palm.
A.
Perfect. Lastly, we are going to look at the deep tendon reflexes. So we're going to begin with the brachioradialis reflex. I'm going to go ahead and palpate the brachioradialis tendon and have the patient's arm lay on top of my arm. We're going to take the pointy end of our reflex hammer, hitting the top of our thumb, and we should see supination of the hand. Next, we're going to look at the biceps tendon. We're going to palpate that tendon, and then we will hit, we'll have the patient put her arm on ours, and then we will hit it with the pointy end of the reflex hammer on our thumb, and we should see flexion of the forearm. Next, we will look at the triceps reflex, and we will have the patient's arm go limp in our hand, and then we will palpate that triceps tendon. We'll use the pointy end again, hit that tendon, and we should have extension of the forearm. Next, we will look at the patellar tendon. We're going to have the patient cross her legs since she's sitting. Next, we're going to have her perform an isometric exercise to distract her from the reflex. So we're going to have her pull her arms across. Perfect. We're going to palpate the patellar tendon and go ahead and hit that with the flat end, and we should see extension of the leg. Next, we're going to have the patient stand up, put one knee on the examination table, and we're going to look at the Achilles tendon reflex. We're going to hit that tendon with the flat end, and we should see plantar flexion. Last, we're going to demonstrate the Babinski's reflex, and we're going to draw an upside down J on the bottom of the foot, and the toes should curl in the adult, and they'll fan out in the infant. And lastly, we're going to use the ophthalmoscope in the ear, and we would assess looking at the tympanic membrane, which should be a pearly gray color, and then we would look for the cone of light, which should be at 7 o'clock in the left ear and 5 o'clock in the right ear, and ensure that there are no perforations. And that concludes our examination.